So let's walk through all of the different drugs and talk a bit more in detail about them. I want to start with levodopa carbidopa. We already understand how it works. So what is the mechanism of action? Well, it gets into the central nervous system, gets then converted to dopamine, and can then just be released from dopaminergic neurons and stimulates the receptors. We need to give it with carbidopa because we need this peripheral inhibitor that's going to prevent that levodopa is just going to be converted to dopamine already in the periphery. So that's going to help us to keep enough levodopa around to get it into the central nervous system. Now, as it relates to adverse effects, well, this inhibition is not going to be perfect, so you're going to still see nausea, vomiting, postural hypotension, and dyskinesia. So nausea, vomiting, postural hypotension is predictable because there's going to be some conversion to dopamine, and that's why you're going to feel some nausea and vomiting. And dyskinesia just refers to some unsteady and unorganized movement. So obviously there are still problems with movements. We have also fluctuation in clinical response, which is often referred as the on-off phenomenon. So when you put a patient on carbidopa, levodopa, it works very well, it works very fast, but then at one point this drug also wears off, and then you're going to see again symptoms of Parkinson's disease. So it is not easy to maintain a constant level of this drug. It has another long half-life. Also food influences the absorption, and as patients generally feel more nauseous, they give it a lot of times with food, which helps with the nausea and vomiting, but then also is gonna not be beneficial to get a constant level because particular protein in the diet is gonna interfere with levodopa carbidopa absorption. So there's definitively some problems which are described as on-off phenomenon. The drug has not fairly constant levels, so it's not easy to maintain constant levels of this drug. Generally, as a clinical pearl, this is a first-line drug for Parkinson's disease. However, you still are not going to give it immediately if the patient has not a certain age. So it depends obviously when the patient is diagnosed and what the severity is. But you want to hold off as long as possible and give it then when you don't have any other options. But then a levodopa carbidopa is a golden standard. Next on our list, another drug class that more helps in conjunction with levodopa carbidopa. These are the COMT inhibitors. They all end in capone, and tacapone is the one that I want you to remember. And it's more a peripheral COMT inhibitor, so that you just boost the levels of levodopa that is available to get into the central nervous system. There's nothing too specific to remember in terms of adverse effects as it relates to entacapone. If somebody heard about a cousin, tolcapone, that has a fairly significant liver toxicity, and that's why it's not very often used. Next on the list are the MAOB inhibitors. MAO stands for monoamine oxidase. It's an enzyme that degrades monoamines. One of the monoamines is dopamine. And so if you block the breakdown of dopamine, you're obviously going to have more dopamine available. And that's exactly what the drugs, the monoamine B inhibitors, do. And the example that we want to remember is selegiline. And I've also drawn that in here so you can see it. Selegiline is going to prevent the breakdown, and therefore you have more dopamine available. It's usually also given in conjunction with levodopa carbidopa, although theoretically you could also give it alone. And there's nothing too specific to worry about in terms of adverse effect. Headaches occur. I also want to mention, some of you may think about, what about tyramine containing foods? Doesn't MAO also break down tyramine, this indirect sympathomimetic that leads to an increase in norepinephrine? Yes, but at that concentration, the MAO is fairly specific for dopamine, so we would not worry generally about the wine and cheese reaction that we see more with MAOA inhibitors, as we have learned in our antidepressant section. So in that concentration, it's fairly specific for MAOB that you use for Parkinson, so you don't need to tell your patient don't drink any wine or eat a lot of aged cheese. So no worries with the wine and cheese reaction with this selective MAOB inhibitor, selegiline. Now we're going to get to our second option. So first option was to do all we can do to increase dopamine, to make more dopamine available. And now we can also say, well, we're just going to directly stimulate dopamine receptors. And how can we do that? Well, with dopamine agonists. And our example that we want to remember is ropinirole. What are going to be adverse effects? Well, pretty predictable. I mean, you're going to stimulate dopamine receptors. So what could happen? Well, you're going to also stimulate dopamine receptors in the periphery. So you're going to see nausea and vomiting, orthostatic hypotension, dyskinesias. Now there's a couple of things that apparently only occur with dopamine agonists and not so much with levodopa carbidopa. One thing that has been reported fairly frequently was excessive daytime sleepiness. So that got as far as somebody just fall asleep by driving a car. So that's certainly something you need to discuss with your patient. And then also something that you're going to hear a lot about and also maybe read in the press is disorders of impulse control. So dopamine, as we know, is involved particularly in the nucleus accumbens for reinforcement. So if you have some good experience, we want to experience that again, and that's facilitated by dopamine. So it turns out that patients on these drugs like ropinirole can see disorders of impulse control as it relates to, let's say, hypersexuality or a lot of gambling or a lot of shopping. So everything that you may usually stop yourself from doing over and over again, but this is now lacking, so that's why you are gonna have problems with impulse control. That's certainly something very characteristic of these drugs like ropinirole or pramipexole that you should know about and that you should be aware and also discuss with your patients. Now I'm getting to the muscarinic antagonists. I already said before, they don't fit really very well into our favorite figure here. We need to think more about the substantia nigra, where there's usually this balance between dopamine and acetylcholine. And once you lose dopaminergic neurons, you have too much acetylcholine compared to dopamine. And so you can fix this with anti-muscarinics, muscarinic antagonists. And the one that is used in Parkinson and that you should remember is trihexyphenidyl. So a muscarinic antagonist. What do they have as adverse effects? Well, we all know muscarinic adverse effects like dry mouth, constipation, blurred vision, urinary retention, all these effects, so not very well tolerated drugs. And then the other problem is, particularly in the elderly, they can cause confusion and drowsiness. So you should really prevent these drugs in the elderly. Well, Parkinson's disease is usually a drug seen in the elderly, so that's going to prevent their use in the elderly population. Now, it turns out as a clinical pearl that these drugs are mainly treating the tremor as a cardinal feature of Parkinson's disease. So if you have a younger patient that comes in with the predominant feature being a tremor, then these are good drugs to start the patient on. You would not start with levodopa carbidopa in a younger patient. You would give such a muscarinic antagonist. So again, we want to prevent these drugs in the elderly because that happens predominantly in elderly patients, and that's why we should not use them in elderly patients, and therefore we're going to use these drugs more in the younger patient where a tremor is the predominant feature of Parkinson's disease. The next drug on the list is Amantidine. It's hard to put it somewhere. I mean, it has a lot of different mechanisms of actions. I mean, most likely it's going to be listed under NMDA receptor antagonist, but that also influences somehow secondary dopamine release and dopamine reuptake. So it's kind of complicated what it really does. It has several CNS effects. You can get headache, dizziness. However, one adverse effect is something that you should definitively know. It's also heavily board tested, something very special. it's a skin reaction that you can get that's called livedo reticularis, and that's a kind of a mottled colored skin, so a marbled pattern on the skin. So you have this mesh-like pattern, and it looks like your blood vessels are gonna be more purplish visible, and that's called livedo reticularis. Nothing kind of life-threatening, but something that's just very typical and very special for this drug, amantidine. That finishes all the drugs that we use for the treatment of Parkinson's disease. So just remember the different categories. Either make sure that we have more dopamine available by supplementing a precursor of dopamine or preventing the breakdown, just directly stimulating the receptors with dopamine agonists, targeting this disbalance of dopamine and acetylcholine, and then we just have this random drug, amantidine. Thanks for watching.